Hello everyone. So today we will discuss about disorders of prostate. But before I start the lecture, I will tell you that some of the students are saying that they are not getting any notification when I upload a lecture. For that, you have to do is whenever you subscribe to the lecture, you have to press the bell icon which is there, and obviously you will get the notification of every lecture I am uploading. So let us start. Disorders of prostate. So a happy prostate becomes non-happy when the patient is having enlarged prostate, and the patient is said, definitely he'll think that what causes this. So the causes for prostatic enlargements are benign prostatic hyperplasia, prostatic calculi, prostatitis, carcinoma of prostate, and tuberculosis of prostate, and some minor vesicles. So the prostate is sad because you can see this is the bladder, this is the urine which is flowing normally because the urethral size is normal and prostate is not enlarged and not compressing the urethra. But what happens in prostatic enlargement, you can see the prostate is enlarged, it is compressing the urethra, some of the urine is not passing through the urethra, it is staying in the urinary bladder, that is giving incomplete evacuation of urine. And also you can see when the urethra is compressed, the flow of urine or the stream will be narrow. So men over 50 years of age are mostly affected by the prostatic hyperplasia, and our lecture will mostly focus on the benign prostatic hyperplasia. But yeah, definitely it will be a gross overview. By the age of 60 years, 50% of men have histological evidence of benign prostatic hyperplasia. Now, the common cause of significant LUTs in men is the benign prostatic hyperplasia and is the most common cause of BOO in men over the age of 70 years. So, LUTs is lower urinary tract symptoms and BOO is bladder outlet obstruction. So, this diagrammatic representation of relation between prostatism, benign prostatic hyperplasia, and urodynamic proven bladder outflow obstruction is like this. So this is very important to add. I'll try to make you understand. Now the consequences of benign hyperplasia can be no symptoms, no bladder outlet obstruction. So patient is having BPH but patient is not having symptoms. So in this area, and patient is also not having bladder outlet obstruction. So only this portion, the patient is having only BPH. Patient can have no symptoms but urodynamic obstruction or evidence of BO. So patient is not having symptoms but the patient is having benign prostatic hyperplasia and bladder outlet obstruction. Patient can have lower urinary tract symptoms and no evidence of BO. So patient can have symptoms and no evidence of BOO. So it's like this. Some component have BPH symptoms but no BOO. Patient can have urinary tract symptoms and BOO. So BPH symptoms and BOO. So this portion can explain everything. Other symptoms can be acute and chronic retention, hematuria, urinary infection, and the stone formation. Now you can see the patient is trying to pass urine in here, but it is dribbling over his feet. So the symptoms can be classified in voiding symptoms and the storage symptoms. So the voiding symptoms are hesitancy, worsened if bladder is very full, poor flow, unimproved by straining, intermittent stream, stops and start, in between dribbling of urination will be there, including after maturation also. This can be an example. Sensation of poor bladder emptying and episodes of neurotension are there. Storage symptoms are frequency, nocturia, urgency, urge incontinence, and nocturnal incontinence. So nocturia and nocturnal incontinence are different things. In nocturia, patient is aware he has to go to multiple times to washroom, but in nocturnal incontinence, the patient is not aware and passes the urine on the bed only. Now, these are the symptoms explain a hesitant interrupted weak stream is there. Patient feels urinating again right after urination, because by that diagram you can see that the patient is having incomplete bladder emptying. Patient having pain while urinating is another example. Patient who urinates can't hold on from urinating is another example, and nocturia is other example. Now the exact cause of an enlarged prostate is unclear and the condition is extremely common among men. So one of the theory is serum testosterone level slowly but significantly decrease with advancing age, but the levels of estrogenic steroids are not decreased equally. According to this theory, the prostate enlarges and the enlargement is because of increased estrogenic effect. The history and examination are most important things to diagnose a patient of prostatic enlargement, and the colorectal examination is a significant examination procedure that has to be done. Investigation that can be done are essential investigation and additional investigation. Essential ones are urine analysis by dipstick for the blood, glucose and protein, urine culture for infection, serum creatinine, urinary flow rate and residual volume measurement. Flow rate can be defined by flowmetry and residual volume can be determined by the ultrasound examination. Additional investigations are prostate specific antigens if indicated, and pressure flow studies are also that can be done. The treatment can be in the form of conservative measure which include wakeful watching in conjunction with fluid restriction and reduction in caffeine intake. So medications may help. Drug therapy is with alpha blocker, or in men with large prostate 5A reductase inhibitor can be added. Now, interventional measures can be included when the patient is not responding to the drug therapy, and these are transurethral resection of prostate, which is the gold standard. This table is from Bailey and Love right now, and if the patient is not improving by any of the procedure, you have to go for the prostatectomy open method. Now there are some questions which are there in the patient's mind. So they will ask, is BPH cancerous? You have to explain that BPH is benign, that is not cancerous. It is prostatic, relating to the prostate gland, and hyperplasia, that is more cells than the normal. So it is non-cancer, but it may coexist with prostatic cancer. Now the next question they may ask is, what is the role of PSA, prostatic specific antigen? So levels alone do not distinguish BPH and the prostatic cancer, but yeah, they may signify something. It can be elevated in both prostatic cancer and the benign prostatic hyperplasia, so this should be kept in mind. They may also ask, are the symptoms related to the size of the prostate? No, the prostate size does not correlate with the degree of obstruction or severity of the symptom, because prostate enlargement is having both static and the dynamic component. The static component, the size may help to determine the symptoms, but for dynamic component, size will not be helping the patient. So after you treat the patient will have a good sleep at night and will thank you